Welcome to Credentially's podcast, your HR healthcare kit.
Good morning, Bill. How are you?
I'm wonderful. How are you doing? Sorry, I'll get my video going there.
Excellent. No, I'm fine, thank you. Very grateful that you've spent the time to talk to me today. Welcome to the Credentially podcast, Bill. We're really interested to talk to you about your experience today and to learn about CareMax. And I'm very grateful for you making the time. So, Bill, tell us a bit about yourself.
Well, it's my pleasure to join you. Thank you for taking the time and asking me to join your group. So my name is Bill Kinch. I am a 39-year paramedic who started off in healthcare, who I actually thought I wanted to be a firefighter, and I realized that people run out of burning buildings for a really good reason. So for that, I decided, hey, let's try this EMT thing, and I never looked back. And what I figured from my learning in EMS was that taking care of people was definitely in my DNA, and it's things that I very much enjoyed. I've been blessed to be in very urban settings, and I've had a great mix of opportunity to care for people with a whole lot of money and people with not a penny in their pocket. And I find myself definitely through my life and career attracted to those that have no money, that I have the ability to connect with, a lot of social issue, a lot of mental health issue that I find to be a super component to the core of who I've become. So over the years, I've had a very blessed career. So in the 1990s, I was part of a disaster medical assistance team here in the US, the National Disaster Medical System, and I was the deputy commander for Boston, Massachusetts 1 team. And what that allowed me to do was to go into devastated areas after certain events. And for me, Hurricane Andrew was my launch event in life. And we went into completely devastated areas and set up urban emergency departments, basically in the middle of nowhere. We converted an old walk-in center. And we actually had a whole suite of paramedic suturing. And the average busy urban ER was seeing about 200 to 250 patients a day. And we were pressing 300 plus people a day through our center. And we did that because what we did is we expanded roles and allowed one surgeon to oversee 10 paramedics in a surgical suite, right? All they did was suture all day long. Being a doc, you know exactly how much time that ties up, right? So from that shifted the whole mentality for me to understand that the way we currently do business in EMS, which was you call, we haul you, was not necessarily the most efficient or best way to practice medicine. And that was in the 90s. And that's really cool that you could be a forward thinker, but it doesn't work, especially here in the United States when we had three words, fee for service, which basically drove a very inefficient and continues to drive a very inefficient healthcare system. That kind of pushed me forward to start relooking at how we should do business. And I figured out very early in my career that the 911 center, 999 across there in the UK and 111 in other countries, 112 around the world, that is definitely the right place to focus on understanding how we can better manage care and throughput. So I became a 911 consultant, and I got an opportunity to travel all over the world, from socialized medicine countries like yourself through areas in India where they had literally no infrastructure. And we had the opportunity to try and create and present infrastructure. And it allowed me a 360-degree view of medicine from all different avenues and how things can be done. And what that allowed now was access to large urban and the most rural of rural services to see how business was done across the plains of healthcare. So having done that, I had now in this point in my life, a 26-year career as a 911 consultant, 39 years in paramedicine, and I've become, as of late, the vice president of transportation for a company called CareMax here in South Florida. What CareMax is they are what we call here in the United States a Medicare C or Medicare Advantage company, and their job or design is to be able to care for patients who have basically entered into their 65 plus years, who want an expanded scope of care and have the ability to expand their regular insurance services. Okay, so Medicare A is what everybody is entitled to after the age of 65. Medicare B is your hospitalization. Medicare C is the Advantage, and Medicare D is your prescriptions. So we are a Medicare C and Medicare D company. And so you're thinking to yourself, okay, so how does a guy with a 911 history and an EMS history wind up working for a Medicare Advantage company? Well, the answer is actually more simple than you'd think. Transportation, EMS, same. EMS is a transportation company with lights on the roof, right? And how we decide that transportation modality is through the appropriate use of triage tools, i.e. the 911 system, right? So that's how I got in front of the group here at CareMax to be able to discuss maybe some different ways of how we could approach things. So across the world, areas are starting to look at a better way to manage patients, right? And I'll talk a little bit more about the CareMax model in a second, but to tie back to how these things come together. In the world of EMS, we're now discovering things called mobile integrated health. Right. So whether people thought that anything ever positive came from COVID, the one thing I think that was positive from the COVID was that it allows us the opportunity to know we can treat people in a more remote setting. It allowed telehealth to come to the table, and it let us know that we don't have to continue with the current broken and inefficient model of how it currently works, right? Being an action in an NA doc, right? You know, people present to your door and you're stuck, right? They come through your door, you own them, right? The best way to be able to take care of that is to know that we have a front end model that allows us to provide the most appropriate care. In the UK, you've been doing this for years. In the US, we're finally now looking at a better way to manage patients on the front end. So how does this all tie together with me at CareMax? So our patients are what's called a full risk modeling patient, which means that our patients are essentially, we take care of them from beginning to end. So we engage in what we call whole person health. So part of what you offer is a Medicare C company, typically is a primary care physician. So you know your regular GP, right? So for us, what that means though is it's not just your doctor. Part of the CareMax whole person health model is that we see our patients 4 times a year at a minimum, right? Because we want to go back to basics and make sure that they're maintaining their appropriate health. The other thing we do is we make sure that they don't become shut-ins or victims of themselves. Meaning we allow them transportation to get to and from things like our activity center. And when you come to our activity center, it incorporates physical therapy, occupational therapy, depression, anxiety, and it allows people to interact, but it also gets them things like their basic meals, like their breakfast and their lunch. So that's why we incorporate that whole person health model to make sure that we have the ability to oversee their entire health risk model. So as we go ahead, did you have a question? I'm sorry, I'm doing a whole lot of talking straight off.
No, it's great, and I don't want to interrupt your flow. I think that's very interesting. I sort of traveled to Tennessee recently and met with a lot of the larger health providers there, and there was this sort of real focus, I think, on what you've described as whole patient health. And they gave an example of, a gentleman that was a Medicaid recipient and wanted to work but had mobility issues and had been prevented from working because he needed treatment. I think he needed an outpatient knee operation as well as the physical therapy. And there was so much that was preventing him from, firstly working as he wanted to for his own health and well-being and to be able to provide for himself and his family, that was sort of not minor to him, but quite minor in the grand scheme of healthcare expenses. And simple things like he didn't have an appropriate pair of shoes, didn't have a winter coat, so he was nervous to go out and to do his physical therapy, to walk around. And I found that so interesting because and it's clear how health is provided in lots of different settings, and it's very impressive to meet someone that knows the NHS lingo as well as the US lingo. But I think there is a big untreated need for patients that isn't just in the the medical acute care or sort of elective orthopedic stuff. It's actually all those sort of small things or small things that contribute to big problems that you are just thinking we need to do more knee operations. You miss an opportunity to help a lot of people, I think.
And it's absolutely true, right? Everything you just said is completely solvable, right? The problem, though, is that in the big scope of medicine, when you simply walk in and understand that, hey, this is just not a problem I can fix, that's exactly how we do not look at things at CareMax. So you made a perfect segue for me into our whole person health model. So one of the differences is that when we have our practices, it's not a sterile medical building. The majority of our practices are actually in shopping centers.
Wow.
They're along major bus pathways. They're along city neighborhoods. They're in some of the lower served areas that allow easy access for our patients to get to us. So you'd come into a shopping center where you'd go and buy your groceries, and your physician's practice is right next door. The other thing is we try and make it a one-stop shop to the very best of our ability.
Yeah.
So when you walk into your primary care physician, you're used to exam rooms and you do your whole component there, right? Well, our exam rooms also have an extension into dentist, optometry.
Wow.
We do physical therapy, occupational therapy, acupuncture, and massage as all part of almost every practice we have out there. In addition, or running in parallel to the side of it, is our activity centers. So we try to incorporate that one stop. So if they do come out and it's difficult for them to come out, we get as much done for them in that one stop as we can.
It makes a lot of sense, because I think there's a lot of people, particularly, sadly, older people that are more stoic and need more care, that don't want to come. They don't want to be a bother, first of all. So it's hard to get them in a consulting, situation in the first place. But then if there's sort of things that they perceive to be small, which again, on aggregate are big, but it's difficult to get them to come out and do, these smaller things. It's also, I really like that you're calling them activity centers, because I think one of the trends that we're seeing as well is a move to try and demedicalize, if you like, the way we engage with patients, calling them service users rather than patients, for example, in an attempt, I think, to make them feel that they're a more active participant in their own health. This isn't something that I, as a clinician, do to you. This is something that we engage in, and that you're responsible for as much as I am as your treating clinician.
Yeah. So just to give you an example, when they come to the activity center, right, that's where they get their food. So they'll have breakfast and lunch served at almost every activity center every day.
Wow.
But they have music. There's a lot of music going on in our activity centers.
Nice.
And so people who need PT or OT, right? So if they have that need, the idea is to be able to get them active and moving. So instead of playing a game like musical chairs, right? That's obviously risky when you're talking about people 75 years of age, right? So we do pass the cane.
Nice.
So the idea is the exact same as musical chairs, except that there's motion and there's mobility and people are passing and moving. And you see people actually using maybe muscles that they don't normally use in that. And you got to just come and see it just one time to see. They scream, they yell, that's competitive, they're having so much fun. And that's just one of the core reasons why I work here, right? Because they just love taking care of people and they just love having fun, right? And why not combine the two?
I'd love to come and see it. So I know CareMax is is based in Boston, is that correct?
No, we're based in Miami. So, so it's a South Florida base. Yes. So I'm a northern guy, right? I'm from up in the Boston area, but CareMax is based here in South Florida. Corporate office, it's okay. The corporate office is in Miami, right across from the Miami airport. I still work I'm a practicing paramedic in a city called Lawrence, Massachusetts. So I commute home and I still work as a paramedic, and my family still lives up in the Boston area. I just work down here. So when it gets really cold over there and you want to change, come on over, visit. It's fantastic here.
Yeah, I was about to say, I do really want to see Boston, but I'll probably time a visit for the summertime. Whereas you can get me year round, I think.
Perfect. Exactly right. And as part of our modeling, we try to make sure that we do the best we can to take care of folks, right? So we're a part of the things that I'm engaging in at the moment is we are looking at creating a single call resolution 24 hours a day, 7 days a week, right? Because we know a lot of people, especially in the elderly years, have difficulty sleeping. And if they're anxiety at 3 a.m., I want to try and provide options for them. So we're building a 24/7 single call resolution call center that allows them at 3 a.m, if they're stressed out about an appointment, they can call us and either cancel that appointment, make a new appointment, do whatever they want or need. Instilling upon that a nurse call triage component similar to the ECNS that you currently utilize across there in the 999 system, where it's triaged based on what their need is by hours. So if they need to be seen in 1 hour, 4 hours, 12 hours, 24 hours, whatever that number is, we have a mobile plan in place to be able to take care of that. So we're engaging on developing a mobile integrated health model that will be built around that. But that model is going to run in tandem with everyday activities such as shut-ins, people who have mobility issues who can't get out of the house for whatever reason, a recent injury, illness, they have an infection that just makes them feel unwell. We'll be able to provide bedside in-home care for that on top of episodic care. so that if their episodic care need is something that is manageable. Obviously, we're not treating chest pain in the home. We're not treating shortness of breath in the home. I mean, this is all reasonable,
brave, right?
That's very brave. But in today's technology, right, bedside troponin, it's not unrealistic, right? Bedside troponin is an actual real thing that happens, right? And now I won't plug the company, but there is a company out there that actually has a bedside. So Siemens Healthineers has a bedside troponin model that if we had a chronic patient who's got a history of anxiety, who complains of chest pain, can I go there and do a bedside troponin? The answer is yes.
Wow.
Right. So if I do a bedside 12 lead EKG with a bedside troponin, and I have the ability to draw any other markers I want, I have the ability to do that with a single paramedic at the bedside in the home.
Good grief. I mean, I don't know if you've sort of followed, and there's no reason that you should, but we're having huge pressure on ambulances at the moment, and we're seeing people wait for a very long time. There's many reasons, the reasons are always systemic, right? But we've got lots of pressure on acute beds in hospitals that's sort of driven by a lack of social care provision. So we struggle to get patients out of hospital when they're sort of maybe medically discharged, but for whatever reason, they're not safe to go back to their previous living environment without intervention. That leads to a backup in emergency departments because, we can't discharge patients unsafely. If they need to go into hospital and there's no bed, they just have to wait in the emergency department, which means there's no where for the ambulance to discharge those patients. So patients have been spending overnight periods or long periods in ambulances, which means when people call and, offer right and didn't have chest pain or have an injury, they're often having to wait hours. There's terrible stories we're hearing now about patients who have fallen, they're sort of query fracture neck of femur, so broken their hip. Their relatives are having to make a tent for them outside to protect them from the elements because it takes so long for an ambulance to get there. And the idea of being able to safely treat some of those more acute or potentially acute things like chest pain without needing to convey someone to a hospital and have them potentially have a long wait to be seen. We do prioritize, so chest pain typically will be seen urgently, but if your resus department is full, if your whole department's full, there's a limit to which you can even do that. So that's fascinating. There was something else I hope you'll forgive me for asking this, but
it's okay.
It sounds too good to be true, right, CareMax? I just what I'm confused by is why isn't everybody doing this, and what's the revenue model? Because if these are Medicaid patients, presumably there is a real pressure on what resources are able to pay for their care. And I appreciate there's often a huge saving if you can avoid someone needing to go in and having an entirely acute interaction. So, it's very expensive for people to go into the emergency room. It's very expensive to have emergency intervention. But what's the revenue model? How is there enough money available to afford all of this amazing music and activity?
So it's all fair, right? So the answer is, so it's Medicare versus Medicaid, right? So Medicaid would be the less, so people that are indigent care, and Medicaid does not equal indigent. Medicaid just means that you have a government insurance that provides you the healthcare coverage. Now, from a model, and you're very fair in asking, the answer is that Medicaid pays about 10 to 20 cents on the dollar when it comes to reimbursement, and there's not a lot of money in that. Medicare pays about 80% of the actual reimbursement component. And when you look at Medicare, these are predominantly Medicare patients, right? We do have Medicaid, we do have dual eligible patients, but the Medicare modeling is built around this advantage. So what advantage is basically insurance on your insurance. Right. So it's called supplemental insurance, right? And the answer around that is that essentially when you engage in that patient, we call them members, but when you engage in that patient, the answer is to try and keep them as healthy as we can, right? So that's why we provide things that we know drive good health, right? The more active, the more moving, the more engaged you have people, the healthier they are. It's almost that simple, right? And they're not lavish places. Like I told you, we're in shopping centers, right? So it's not a big rent to be able to get in there. And, the transformation of space is literally walls and being able to build some of these things around it. If you provide all those services, why not just provide them under one roof, right? So sure, there's a big expense in dental chairs. Sure, there's big expenses in optometry machines, but that doesn't mean that we have an optometrist in every location, right? We might only have optometry in one location on Tuesday, the next location on Wednesday, and so on. So there is shared services within our services, right? And it's about being able to do whole patient health. So yeah, it's a risk modeling, meaning that there's risk. So obviously, like you said, every time that patient presents to the A&E, it's not good for us, right? Because now we have no control over what happens. And remember that, well, you don't know this, I haven't said it. The mean age of our patient is 75. So when you take a 75-year-old patient who presents to you as an A&E physician and they have a vague chief complaint with multiple comorbidities, that is an absolute nightmare for an A&E doc, right? Because you're like, I'm not figuring this out. Admit them, move on, right? Done.
Kill you in 4 hours, if not,
right?
That's
it, right? Exactly, right? Because you're not going to spend your time trying to figure this out, nor are you going to take the time to change their high blood pressure medicine, nor do we want you to, right? What we want you to do is send them back to us. The optimal in that component would be, hey, I've got your patient here. What can we do to get them back to you? But that doesn't happen either, right? Because now nobody's going to do that. And when you talked about throughput, which is really what we just talked about, right? Is it is only so many rooms in the inn. When the inn's full, the inn is full. And the throughput problem in all of the world is that we don't have enough non-emergency services to move patients, and we don't have enough places to put them. I mean, in my humble opinion, I've been doing this a long time, right? So 39 going on my 40th year. Behavioral health has never improved in the 40 years I've been doing this, right? Behavioral health continues to become we're the gatekeeper for almost every aspect of medicine in the emergency services side, right? Because when you call us, we have to do something with you. Even in socialized medicine countries, there becomes a point when we've got to do something. If somebody's depressed, that's one thing. But if somebody's violent because they're having a psychotic break, they're coming to you one way or another, right? There's no difference in that model when we talk about aged care, right? Because the problem becomes patient's primary care physician closes at 5. Most of our physicians are available on an on-call model, right? But each physician probably has a panel of 1,000 patients. So that can become completely overloading. So what we're trying to do is to build sustainable infrastructure that will allow patients access and they get to the right person to get the right care, right? So that's the design, right? The model will be to be able to know that they don't have to talk to the doctor every time. They don't even have to talk to a nurse every time. Right. So we have a tiered approach, tier 1 being appointment changes, appointment cancellation, questions, billing questions that we can refer to the next day if it's an after hours thing, right?
Non-clinical and
that's it, right? And then you tier it up. Exactly, right? So because there's the key, access. That's the key word, right? It's getting people the right access to care and then providing that care based on how that's going to work.
That brings me to, there's a couple of things I wanted to talk to you about. So we've seen during COVID, necessity really is the mother of invention in healthcare. I suppose you can argue that this is a positive, but it's an industry that is very judicious in how it moves. It doesn't want to take a risk on a new model of care. And that's good in that, none of us want to be exposed to risk as patients. We want to know that things are safe and have been tried. The problem is it means that the evolutionary rate of healthcare compared to other industries can be quite slow. And so, as you say, remote clinical care, we've actually had the tech to do that for quite a while. I think it was sort of possibly in patients and in clinicians, but the willingness to adopt that and the perceived risks versus the perceived benefits. And I think now we've clearly seen that for many cases, remote clinical is a great first step where you don't need to acutely examine someone or provide them with an intervention that requires an in-person consultation. And then I think the thing that you talked about in your sort of emergency response, that the first thing that you discussed with sort of having a factory floor almost of EMTs suturing overseen by a clinician, and the throughput you must be able to get with that is pretty amazing. And I used to love suturing people when I was in emergency medicine. You get to sit down, put out all your tools, focus on what you're doing, and to the exclusion of everything else. But it does, you can suture a few patients an hour if you're very good and you're doing nothing else. But that's not just your job as an emergency clinician. You're supposed to be diagnosing, triaging, moving people through their journey. And so having people perform, and this is an expression I think we've heard from the US, at the top of their license. So allowing people to do the thing that they're the rate limiting step on, usually, which is, clinicians, the rate limiting step typically on prescriptions, although nurse prescribing is helping with that on admissions typically, although we've got a lot of nurses being able to admit to a hospital in the UK now. And, nurses often are the rate limiting step in the delivery and administration of drugs that are prescribed. And So what we see as a problem in the UK, and I think it might be because we've gotten used to a workforce that's provided centrally and that is provided fairly cheaply, I would say, compared to what their skills are worth in other countries, is that it doesn't give as much pressure to have people always performing at the top of their license. So you end up as an A&E doctor pushing your patients around to radiology to get their scan because you can't get a porter, and that's good for that individual patient, but for the department as a whole, it reduces its throughput. So I love that idea, and I think that's the other advantage of having all of those specialties that you mentioned in your activity centres together, is that you can get the patient while they're there, make sure that they get a lot of intervention if they need it, but also have people, I don't want to say on a production line because it's a caring profession and it's as much an art as a science. It's a very human thing, but so I don't want you to think I'm callous when I say as a production line, but just in terms of efficiency, getting the patient to have as much value as they can out of one interaction, I think is very important, and that full team approach must really help with that.
Exactly. And that's exactly right. That's why, the initial campaign we're starting is called Call Us First, because we want you to give us the opportunity to serve you as our patient and give us the opportunity to take care of you. And that's why this whole service delivery model is being kind of rolled out, to be able to, one, let patients know we are here to care for them, and that we do know them better than the average corner urgent care, or that and not that the urgent care wouldn't take good care of them. It's just that we know you because you're our patient.
And I think that's something patients really crave. They don't want a transactional interaction with certainly with a primary care physician. And I think there's a huge benefit to having that, someone that knows if you look unwell, like you don't look like yourself, what's going on. That's actually, it's somewhat intangible because you can't put it in the notes. Well, you can, I suppose, but we've really lost that, I think, largely, even in the UK, where most people will go and see the same general practice consistently for a long time whilst they're in an area. But the model that we have of, you have your GP and that's the primary care physician, and that's the person you go and see and they know you, largely that moved to, you'd see a different partner, whoever was available. And now I think it's changed even more to, often there's sort of salaried or locum primary care physicians that move around the practices, and so it's even harder to get that continuity of care. So I can certainly see why that's hugely desirable for your patients. Sorry, there's one more question I wanted to ask you that I'll kick myself if I don't ask. So I understand, and apologies for getting it wrong, that you are providing care to people in most cases that have this supplemental insurance. In terms of the revenue model and the revenue benefit, then, is it that the providers of that supplemental insurance are seeing that the healthier they keep people, the lower it reduces premium? So similar to how in the UK health insurance providers will give you a discount if you go to a gym, and they'll have a partnership with the gym. Is it similar to that? That's
yeah. So let's use some direct clinical terminology, right? So if you're a diabetic and your A1C is above 8, right? That's a parameter that I can measure. That is a measurable component of a risk, right? So the higher I allow your A1C above 8, the worse it's going to be for you in a prolonged outcome, right? That's a measurable component. That would be something we're measured against, right? We're measured against patient satisfaction. We're measured against A1C. We're measured against high blood pressure. We're measured against compliance to medication. So yes, the benefit is to keep you healthy. So that's why we not only make it that way, but we make it fun.
Yeah, and the commercial driver for that comes from the providers of that supplemental insurance to reduce their overall premium payouts. Is that
the payer? Correct. So the primary payer, so CMS, are you familiar with CMS here in the United States? Yeah. So Center Medicare Medicaid Services, right? There, no matter what anybody tells you, they're the largest payer of insurance here in the United States, right? And then CMS basically puts this Medicare Advantage. We're in the middle of open enrollment now. It's AEP is what they call it. Annual enrollment period, where people and it's almost like political ads. It's terrible. Every time you turn on the TV or you're watching these, open enrollment ads, and you're seeing over and over about all these, right? You're like, oh, please, enrollment ends soon. And I say that jokingly because that's the bread and butter of what we do, right? But the reality is that as these seniors see opportunity, they learn about things, about services and things that they didn't necessarily have access to, that this extended insurance offers. So what it is basically putting their Medicare benefits on steroids, giving them extra things like access to an activity center, access to transportation when you're stuck at home and you don't have the ability to drive. All that is part of their insurance benefit, right? So it's about maximizing your benefit. The model is around, and let's just kind of, I don't mean to sound sterile, but I'm just going to make it that way for the ease of understanding. These patients basically become, you can purchase them, right? So for lack of a better term, we purchase that patient's care model for X dollars, whatever that X dollar amount is. And then the more efficient you become, the better you are at getting reimbursement based on that, right? So if I allow every patient to go to the emergency room for every hangnail and cuticle issue, right, we're in big trouble, right? Because that would fail the model. Where the model is designed about not only whole person health care, right, but being able to make sure that they stay healthy. That's why we see our patients 4 times a year. And we call that model back to basics, right? Just get back to the basics of seeing our patient, understand what our patient's needs are, and meeting those needs.
Okay.
Did that make any more sense? Sorry.
Yeah, that was extremely helpful. So yeah, thank you. If it's all right, I'd love to get your perspective, particularly as a clinician, but on the workforce challenges that we're facing. I can see why working in an organization like CareMax would be very desirable for practitioners. We're seeing certainly that after the brutal 2 years everyone that works in healthcare has had, people are now thinking about their own health, their own lifestyle, and their own caring responsibilities when they're looking for a new role. But everyone we speak to, top to bottom, private, public, is having massive workforce challenges. How are CareMax finding it in attracting and retaining staff? And yeah, what do you see as sort of any best practice you've seen there?
So there, and I'm just going to talk about my division in particular, if that's okay, which is the transportation side. All right. So now we have 186 employees. We have 172 vans. We have 162 drivers. And I'm just going to put it out there for an understanding. So from the per dollar hour, we're about $2 an hour behind the next payer. So essentially, if somebody makes $15 an hour, we're paying about $13.75, right? We have 100% staffing.
Wow.
100%. So how do we do that? The answer is, one, we care about our people and they know it. So if you have a family emergency, you have a problem with your child, you have something you need, just come talk to us. We will work with you to do what we need to do. We try and make it so that it's adaptable. We make it so that it's a fun place to work. We make it so that you matter, right? So when there are, for an example that I'll give you is one, as the leader of transportation division, I empower everybody to make whatever decision is going to work well. But here's the other thing, you own it, right? If this is your idea and it's important to you, do it. And you own it, it's yours. My job is to support you to do your job to the very best of your ability. And that's literally all I do, is I just make sure that they have the tools and the resources they need to do their job. Beyond that, is we look at how do we sustain and retain people, put it out there. Don't be afraid to hear what your people want to say. So our very first employee retention survey that we just finished, we have 162 drivers, 110 replied.
Wow.
Right. So when you talk about a survey tool and the driver of the survey was, tell us what you like and tell us what you don't. You are completely anonymous. I don't know if it was you, Kit, you could have sent that in and it would have been you that answered it. I would have no idea. Right. But the reality is that they understood that I'm about transparency. If you want to tell me we're bad, tell me we're bad. I'm okay with that. But tell me how we can improve. Don't just tell me I suck. Oh, sorry. Can I say that on this? Sorry. Okay, so just don't tell me that I'm bad. Tell me how I can make it better, right? And that's the philosophy we're using to try and make sure that people understand that they care. Our drivers talk to our patients all day. They're the first person to see them. They're the last person to leave them at home. We're transitioning a program to make them ambassadors of CareMax, right? So that now they will be empowered to be the ambassador. They're out there. They drive our vans. They wear our uniforms. Be our ambassador. So we put them all through ambassador style training that lets them understand and how that works. Part of that process was they came to us and said, hey, we hear this stuff from people, but we don't know where to go with it. So we took that piece of information and we created an internal service assessment line. So essentially we have a line that's dedicated just to the drivers, so that if they come upon an issue, problem, occurrence, they have this phone number that they very simply call up. That generates a ticket in a program we have a Zendesk That generates a ticket in Zendesk that now allows us to know that that issue's been reported, and it allows us to close that issue so
Good.
that we know it doesn't kind of remain out there in the air.
Very impressed with the operational structures that you have, and they seem to be, there's a lot of communication, when you're talking about getting patients to call you up at 3 a.m. because they want to reschedule an appointment. The burden of unattended appointments is so huge, that I can imagine that being very beneficial to patients, but also very beneficial for you as an organization.
Right.
I've heard of people trying to do it, albeit not to that extent with the patient-facing stuff, but having that for your internal staff, an efficient ticketing system that they can use, it's really powerful. And I think it makes me think, and the level of engagement you've got from your employees is probably very helpful for you having that clinical experience and, past and current, right? You're not just sort of top down operating by dictate. You very much know what it's like to be at the sharp end. So you can really feel that, right, in the way that you're discussing this.
It's for people that are watching this that are new into healthcare, right? Please don't let the current situation drive you to think that this is how your life is going to be, right? Because those of us who have been around for a while now know that, healthcare, we have our ebbs and our flows, right? Yes, COVID beat a lot of us to the ground. There are a lot of really good people that left this industry because they just can't take it. There are a lot of good people that are burnt out because the conditions in which we work in are beyond difficult, right? And we see it. We see it on the news. We see it on the throughput, like you talked about. What we called, when you talked about the ambulances being installed, we call that wall time, where we see an increase in wall time because they're just not putting patients on stretchers, because we put them on a stretcher, wheel them in the corner, they get forgotten about and they die in the corner, right? That's just not good healthcare either. But that just begs the question of, why aren't we looking to do it differently? Now is the absolute time. I can't think of any better time than a complete employee crisis to relook at how we do things. So as we, right? I mean, if I'm wrong, tell me I'm wrong. I'm okay with that.
Necessity is the mother of invention, right? We do not have a choice at the moment.
And we're there.
Yeah.
We are there, right? And if you take a look, especially in the UK, I'm sorry, go ahead.
No, I really admire I really don't want this to be misconstrued, but paying $2 an hour, for example, under what the average is, I think forces you, and then doing that because employees know that they're taken care of. There's this huge misconception that most people that get into healthcare do it because they want to get paid a ton. And actually, with the level of training and skills that you develop, the level of your workload, you can do it a lot more in many other industries. People do it, I think, by and large, because they feel, as you described, compelled to care for people and that it's very meaningful. And so I think our nurses are about to go on strike for the first time in 100 years, it looks like, and they have been offered a pay increase, but not one that is in line with inflation. But it always occurred to me, I was involved in or my profession was involved in industrial action back in 2016 when our contracts were changed. And it always occurred to me, actually, you could get away with paying clinicians less almost if you treated them better. I had colleagues that wouldn't be given a day off for their wedding, despite telling healthcare staffing, months in advance, colleagues that struggled to attend their own father's funeral for similar reasons. And that's what grinds people down more than anything.
And I mean, shame on administrators. If you don't think we don't talk to one another, come on, man. That story is going to carry forever, because that story of not being able to go to your own father's funeral will be 100-year story and never lose its age. Never. Never, exactly. Right? And why would you put yourself as a commercial entity in that way, right? Why would you do that to people? It's just being kind. And we are in an industry that requires us to be kind to people. So that if you can't be kind, you got to treat your people kind, right? And you're right. Our drivers who maybe work a little bit less, but they know they're your patients. These are your people. However you want to treat them and be kind to them, it's all you. You want something for them, you ask us, we'll give it to you. They need a ride because you can help, give them the ride so you can help them, whatever it's going to take to make their day and your day better. And it's not hard. The majority of what you just talked about is not hard, right? We almost worked against ourselves often, but especially like in an aging workforce, because those are the only ones of us that are pretty much left, right? We're not young. So as we kind of, and I'm excluding you from this, you are young. I am not young, right? But if you provide opportunity for people in their 30s, 40s, 50s that will have a better pathway that allows them to be able to stay active in medicine, but not carrying somebody down 3 flights of stairs, is really a good way to continue to keep the industry moving the way the industry needs to move. We need to provide not even up, lateral's fine, but give them lateral that continues to challenge them yet incorporates healthcare. There is a ton of opportunity for improvement here. And throughput, like you talked about, parking people in hospital beds, hospitals are the worst place to get better. Nobody sleeps in a hospital. It's loud.
They're dangerous
right?
places, yeah.
It's dangerous, right? You go in to get your hand sutured, you come out with COVID. I mean, come on. There's a whole lot of better ways to do a whole lot of things. This isn't a big stretch, right? Everything we're talking about is all quite manageable, all quite doable, can be done much more cost effectively. And it's better for the patient. When you don't feel well, leaving your home is the worst idea on the planet.
Yeah, that's a very interesting approach. Just, I wanted to come back to something you said about, the healthcare workforce and being able to meet the needs of a workforce that is aging. And we're seeing scary things about the number of clinicians that are going to take early retirement, nursing, physicians, allied health professionals. I've seen similar data from the US, particularly in nursing. There's a real concern that nurses are retiring at a rate that they're not being replaced. And I think what you've just described, giving people a way to move laterally, to take on, to be able to continue to have the privilege of providing healthcare, but to do it in a way that is sort of sensitive to the fact that their needs are different, than those of a younger person, I think is going to be really crucial to retaining that knowledge capital, because it takes a long time to train a clinician, and it takes a lot of resources. And there's, even with unlimited money in the world, we can't click our fingers and make new, primary care physicians, new senior nurses. It just takes a lot of time.
And how do you train experience?
Exactly. Yeah.
Right. Experience is earned, right? And it's time to start focusing on using people's experience and working it for the better. And just one more feather in CareMax's cap. The mean age of the drivers is 57.
Wow.
So it's not like we have a young workforce. They work because they like it, right? They enjoy it. There are some people that are retired, right? They're retired and they drive for us because they're retired, right? They want to just have something to do. And there's others that need the job, right? So the others that need the job, like you talk about inflationary survival, right? That's something I'm fighting for. But I also have one of the largest departments within CareMax. So, when you talk about an across the board raise, it's not insignificant, right? So I'm also fiscally oriented in the respect that, we've got to keep things within line, because we are transportation is not a revenue generator. It's not like we can transport in an ambulance and get paid for that. This is part of the service provision, right? So it has to be kept within fiscal responsibility at the same time.
Yeah, that's it's very impressive. I think what you've achieved with that workforce, and it means your patients get the benefit of experienced practitioners as well. And I'm sure that best practice is represented in the other departments of CareMax. But it's very impressive, and that average age of the workforce, it just shows how good you are at retaining people, I suppose. Best practices. It's interesting to hear how you get good people, even though you don't offer the best rates of pay compared to the market, and through taking care of your people. It's great to hear about retention and retention of that knowledge capital. I'd love to hear about, in your experience, I'm sure you've worked for many employers, what you've seen done badly, and what acts in your head as like a guiding light of do not do this for retention and attraction.
Wow, that's a long conversation, right? So there is a lot of things do not do that kind of carry across in my life, but I'd rather talk about the do's, right? So that if we do this, the don'ts would be the opposite of what we talk about, right? And the answer is simply just one: treat people as they'd want to be treated, right? And there are plenty of people that are power hungry, or they like to be the boss, or they like to be called the boss. None of that, right? We all work together as a team, and everybody on the team needs to know that from the top on down, if I need to go out and drive a van, I'll go out and drive a van. Right? Whatever has to be done, you do what has to be done, right? And you keep that, and you just do the things like you talked about. Somebody's got a birthday, and if I was king for a day, you would never work on your birthday. It's the one day of the year that's yours, that nobody can take away from you. It's yours. You share with others, but that's your day, right? So for me, I would love to have everybody who has a birthday, that's your day off, paid. You're paid to have your day off.
Thrown in that case.
Right? Because I mean, why not? This is your day, So let's just make the best of it. And if that means coming to work is what makes you happiest, come to work. We won't make you stay home, but plenty of people would have just a great time going to the beach on their day off, knowing I'm getting a paycheck today. Woohoo! Right?
Yeah.
That's is it fiscally? Does it cost money? Sure, it does. But then again, like you talked about, so the average cost to retrain and onboard even a driver, $5,000. $5,000. That's not insignificant.
Yeah.
Right.
That's
and you're talking about
would be actually.
So, and that's a driver, right? So you're talking a $15 an hour job is a $5,000 onboarding process, right? This is almost easy math. Just do what it takes to spend a little bit of extra. And like you said, throwing money at people isn't the solution. I've worked plenty of places that throw big money bonuses around all the time and still can't get shifts filled. What's that tell you? It's not the money. It's the environment. Fix the environment, right?
I completely agree. And I think often the places I've seen that pay a lot are the places that rely often on, I don't want to say transient labor, but locums, short-term placements.
Yeah.
It's really hard for an organization to dig itself out of that hole. If you're chronically understaffed, it becomes a stressful place to work because no one knows anybody. Often people don't have access to the clinical systems they need to. Everything's inefficient. Yeah. Even if you're paying, and then you end up paying way over the odds as an organization. Yeah. But you still can't attract and retain the best candidates that have a choice of place to work because it's a stressful environment. And that, one thing that stuck in my mind about what you said was, well, we've got 100% staffing. And it's like, that is so rare. Of all the people I speak to doing this.
We have 10 applications on file for people ready to come to work for us. Wow. Yep. But what we do is we offer opportunity, right? We tell people, sure, you can come here. And if you want to do something, then work at it, right? I tell everybody, if you want my job, take it. It's all yours because all I'm going to do is elevate because you're pushing me up, right? We're just doing it all together. You want my job, come after it. I have no threat by anybody because the reality is you want my job. There's lots of work to do. Step on up. We'll certainly provide it for you.
You've got a very healthy and very rare, I would say, approach to leadership that I think perhaps comes from being at the sharp end. But I'd be interested to know what your leadership influences were because the sort of, being prepared to be the chief cook and bottle washer, jump in a van if you need to, having that, the really good communication with people, giving them autonomy, backing them to make a decision if they think it will make them more efficient. These are all things that really drive innate motivation within an organization rather than just, we will pay you this amount of money to do something you don't want to do. And if we make the thing you don't want to do worse, we've got to pay you a bit more. Like that's a really toxic bargain. So I'd love to know what your influences have been in leadership.
It's actually one person. It was my father.
Wow.
My father was always that type of guy, right? And for me, I've been fortunate that whatever leadership position I've gotten into, because I used to love when people would say to me, how do things fall in your lap? They don't. Nothing falls in your lap. You create opportunity and you make it. So if you want something, go after it, right? And if you see opportunity, make it. If you've got an idea, present it, right? And it's, I'll never be rich, unfortunately, because I talk too much and I give too much away. But at the same time, right, if I died tomorrow, I'm quite at peace, right? And for me, the leadership style I've gotten is because I want to lead as I would want to be led, right? So that if I look at somebody and know, you've never done my job, so please don't tell me how to do my job. And I don't, right? I go in to get my haircut, which is not much left. It's a pretty easy job these days. But when they say, how do you want your haircut? I'm like, you wouldn't tell me how to do my job. I'm sure as heck not going to tell you how to do yours. And I literally lead that way every day of my life, right? Because the answer becomes, listen to your people, because when I tell you I was a consultant, right? My favorite line as a consultant was, the only thing I do is I come from greater than 50 miles and carry a briefcase. And when I kick my way through your door, guess what I do? I listen to what your people are telling me. Because by the way, I'm not going to figure out your organization in the 3 days I'm here. I absolutely need to ramp up very quickly and hear what it is that you've got to say. And then you can choose to implement what your people have been telling you to do all along, but I may put some spin on it. I might be able to fine tune some of the business process, right? But the reality is that your people know what it's going to take, right? You know who those leaders are. You know who those insightful people are, just the way they speak and they present. Listen to them. And that's the leadership style I've always adopted is, And the other thing is just be honest with people, right? Just don't make stuff up as you go. If it's not a good answer, tell them you're not going to like my answer, but this is the best one I'm going to give you, and tell it to them. People are okay with the truth.
Yeah, I think certainly people, if they believe they will be told the truth reliably, they're a lot better at hearing uncomfortable truths, because they know they're being told it because they need to be told it. I think all of the things that you're talking about, all of these things that I see to be very positive leadership qualities, they all require a very humble the ego, I'd say. Unfortunately, being at the sharp end of medicine, which I think EMTs really are, it is nothing but humbling, and gives you a good perspective. I always was very grateful to EMTs as an A&E doctor that my patients would come nicely wrapped with all the bits of them scooped off the road that needed to be.
Yeah, exactly right. All the parts and pieces showed up in one package.
Yeah.
So, and that's just it, right? That's a very humbling experience when you're in the midst of somebody's worst day of their life, and you're there trying to manage their family. And I'm very good at managing a patient. I'm very good at managing a family. I'm not good at managing all the above at the same time, right? So that's the other thing you got to learn. You got to learn your strength. You got to learn your weaknesses, right? And for that, when you hire or put together a team, you hire people much smarter than you. If you want to be a good golfer, golf with golfers that are better than you, right? There's no difference in the workforce. Surround yourself with people that are motivated, people that want to make change. And there's that C word, right? Watch out for that word change. Nobody likes change. Well, guess what? Stagnancy certainly doesn't work. In the history of time, it never is proven to work, right? So
constant.
Right. And that is the one constant. It has to be, though, right? Because like you said, we're going to be forced into a workforce and a demand on healthcare that's never been seen in the history of time. We are about to enter unprecedented times, and it's dark. It's not even pretty. It's dark. Right. So the reality becomes is that at what point is there the benefit, right? How is it that we change this trajectory? And I'm not sure I'm smart enough to answer that. But the reality becomes is that it's about making an environment that is going to foster us caring for people. So let me rephrase that. People who get into healthcare get into it, some for money, very few. They get into it because they want to make a difference and they want to help people, right? Foster that. So that means you have to hire 2 more housekeepers so that you don't have a doctor pushing a broom, right? That you don't have a doctor running people to down to x-ray because they just got to confirm whether it's a fracture or not, so I can move them out. But it's those simple things, right? That throughput's important, process is important. But then again, creating a factory and making it sterile doesn't work, right? It doesn't work. When you have a waiting room of 80 people staring at the wall, yelling at people to get through that door, there's got to be a process that's better, right? So do we put a doc out there and discharge people out of triage? Maybe. If that's a better throughput. If we have a deep urban A&E that's stuck in the middle of the city that we know, we are people's access to primary care. Now in the UK, you have 24-hour urgent cares and GPs that can be seen. We don't have that here, right? We have freestanding emergency departments, but
we still have people pitching up to A&E because it's the brand, if you like, that they know they can go there in a way they can be seen. It's actually, we have 111, which is a very good triage service, but is feeling a lot of pressure like everything, and people do end up turning up to emergency departments. I sympathize with what you're saying.
And we have no idea what long COVID's going to do, right? When I first started talking about COVID, and I told people, I said, we are seeing things we've never seen before. I mean, you've been doing this a long time. When's the last time you saw a 40-year-old non-menopausal female have a heart attack?
Yeah, it's quite disturbing, isn't it? And I think we're going to see long COVID response syndrome as well, with the delays in speech and language acquisition for children that we're seeing, the explosion in mental health needs, top to bottom, but particularly in young people have been trapped inside and terrified for a period. So yeah, I think
and all of that's real, right? That's why I was talking about behavioral health. We are now seeing unprecedented numbers of people, right? Because we had no idea the impact. The other thing we're seeing over here is we're seeing an explosion in RSV because everybody's wearing face masks, right? So now we have all these underdeveloped immune systems that are just getting crushed by a simple virus, right? So these are all side effects that nobody predicted, planned, or is ready for. And these kids, when would you ever think that you would look at somebody with an O2 sat of 70 and think that they're perfectly fine because that's what it's supposed to be happening, right? I never in my life would have thought that leaving somebody with a sat of 70 is a good idea. But we now learn that, happy hypoxia and the use of COVID and what we should not do, which is intubate those people. We've now come to a whole different school of thought.
It's funny. So we could talk about this for several hours, but
I'm sorry. I keep digressing. I apologize.
No, this has been, I think this has been one of my favorite conversations of all that I've had in doing this. So Bill, I want to thank you sincerely. I've really enjoyed it. And I think there's a lot there that our audience is going to be very interested in. Bill, I'd love to, thank you again for your time. If there's anything you'd like to say by way of an outro about how people can get in touch with you if they want to or find out more about CareMax, we'll put it in the show notes, but it'd be great.
My email is bill.kinch@caremax.com. Feel free to hit me up if you have any questions, you want to expand the conversation on things we've talked about, be more than happy to engage.
Fantastic. Well, Bill, it's been a great pleasure on behalf of myself, the Credentially team, and our audience. I'd like to thank you very much. I hope we can talk again because I've really enjoyed it. And
feel free, reach out, my friend. I'd love to continue the conversation, especially if you want to kind of bolster on the leadership stuff. Would love to chat at any point in time.
Fantastic. Brilliant. Well, with that, my dog's decided it's time to have a shake up as well. So clearly
perfect timing.
Brilliant. You have a great time.
You too, kid. Thanks, kid, man. You have a good day. Bye-bye.
Search Credentially for your current healthcare staffing insights.